All right, so welcome to today's live stream. We're going to do a presentation on mechanical ventilation, looking at lung mechanics and protective lung ventilation. My name is Jason. I have 25 years experience as a respiratory therapist. I work currently as the clinical educator at my hospital in the ER, as well as the ICU. So let's just jump right into the presentation. So for this presentation, as a little summary, we'll go through the plateau, total Peep, drive pressure calculations, looking at compliance and that calculation, as well as resistance. Also, just looking at the physiology of breathing, looking at pleural pressure. So we'll touch a little bit on transpulmonary pressures and how they can sometimes correlate well with the drive pressures during mechanical ventilation, and when the drive pressure as well as the transpulmonary pressures no longer correlate. And that'll have to do with chest wall compliance. So we'll get to that part when we get to that part. The typical 6 to 8 cc's per kilogram of ideal body weight is what we do for tidal volumes for protective lung ventilation. We can go down to as low as 4 to 5 slightly lower tidal volumes for patients that are in adult respiratory distress syndrome. The plateau pressures for protective lung ventilation are to be kept below 30 usually, and obviously the drive pressures for protection is under 15. There's a literature in a healthy lung, probably 14 to 18 as a drive pressure is considered likely acceptable and non-injurious. The last thing that we'll touch on is that now that we have all the basics of protective lung ventilation, the normal values, is we have to start looking as well at the stress and the strain of the lung, and not looking at the lung as a globally. It's like we have to understand that in a sick lung, the lung distribution, the ventilation that's being distributed is very heterogeneous. So we could look at the global values and say, yeah, the lung is receiving 6 cc's per kilogram, that's safe. But if you have a de-recruitment in your functional residual capacity, that means, let's say it's half of what it is supposed to be. Then when you're delivering a certain force, a certain stress to the lung, if all the alveoli are recruited, then the stress and the power of the ventilator, what we're delivering to the alveoli, will be nicely and evenly distributed. So that stress will be distributed evenly over a large surface area, let's say of alveoli. And but when we have de-recruitment, and let's say we have 50% of what our functional residual capacity is, so 50%, let's say, of the alveoli are shut, and we are doing 6 cc's per kilogram, does the alveoli, the alveoli, looking at the micro level, do they really feel like they're safe? Do they feel like they're receiving 6 cc's per kilogram? No. Half of their friends are gone on vacation. So the stress now that is being delivered can make the alveoli feel like they're 12 cc's per kilogram. And then after, we know that of the alveoli that are open, even within the open area that's taking part in aeration, there's different time constants. So the alveoli that are more compliant, technically the healthy ones, might not only receive 12, well, they're going to open up first, so they might receive up to 16. So you can see how this can cascade into a mess. So for protective lung ventilation, optimal lung recruitment and recovery of the functional residual capacity is extremely important on the micro level. because the alveoli can potentially receive, 3-4 times the amount of volume because of one, the derecruitment of your functional residual capacity, and then the heterogeneity, like how heterogeneous and different the areas of the lungs are. For tricky situations, you have two options. My option is to use electrical impedance tomography that gives us a dynamic view of the distribution of ventilation in regional compliance areas. But we're not going to discuss Palma Vista or electrical impedance, but I am a huge advocate of this. And this is a way of individualizing ventilation to create a more homogeneous distribution of ventilation, and that overall will reduce the strain. So stress is the power being exerted over a certain surface area of alveoli, and the strain is the deviation or the change in the shape of the alveoli. So we're dealing with volume. So the alveoli have, first of all, depending on your PEEP, there's a certain stretch and strain that occurs to keep that alveoli open. And then after, you have a secondary volume, right? You have a volume on top of the PEEP being delivered. And so strain and stress, when you're looking at the lung, the more stress that a alveoli receives is proportional to the strain, because the more stress it has to deal with, the more that specific alveoli will be distended, and that is what strain represents. So I'm going to be quiet. That's kind of the general idea of the stream, and we'll just get to the PowerPoint presentation. Just want to make sure it's popping up here. Looks good. I'm going to start the slideshow. Perfect. All right, so pulmonary mechanics. So we have compliance as well as resistance. So these are basically the two forces that will oppose the expansion of the lung. So we have the elastic forces. We often talk about compliance. So that is how easy the lung will inflate or distend. And we also have elastance, which is the recoil of the lung and its desire to return back to the resting position. So compliance, how easy the lung is expanding, and elastance is the recoil of the organ, the lung, back to its resting position. So how it wants to snap back. So high elastance will cause issues, low compliance. They're kind of a reciprocal of each other. Looking as well, we have the frictional forces. We focus on, the airway resistance, but, just as a side note, there is as well the frictional forces, the resistance due to the tissue viscosity of the lung itself. But we focus more on the resistance through the airways, and that's influenced by gas density, the length of the length as well as the diameter of the airway. We're speaking about the artificial airway, the ET tube, as well as the conducting airways, all the way down to the tinier airways. So length and diameter, and then after you have the speed of gas flow. So flow, obviously, the more flow that you have, the more resistance. The smaller the airways and the longer they are, the more resistance. Gas density, think of why we'll give heliox in, let's say, asthmatics or obstructions in the airway, is that the gas is less dense, therefore it will reduce the resistance to airflow. So work of breathing is basically the energy to move air in and out of the lungs during breathing. And this is heavily influenced by compliance and resistance. So the minute that you start having, a decrease in compliance, whether it's chest wall compliance or lung compliance, or an increase in airway resistance, you will have an increase in work of breathing, and the patient will assume these efforts, leading to dyspnea, rest distress, and eventual fatigue. Looking just at the normal physiology of breathing, we have our diaphragm, as well as the muscles, the respiratory muscles, intercostal muscles, and we also have the accessory muscles that can take charge also for deeper breaths. But basically, the normal physiology of breathing is that in our pleural space, it's about -4 compared to the pressure inside the lung, and that's what creates our physiological PEEP. So that negative pleural pressure that is about less than 4 will keep the lung expanded. All of a sudden, so when we're resting here, it's let's say atmospheric. It's equal also atmospheric here inside the alveoli. We haven't started breathing yet, and we have this -4 that is outside the lung, that is holding the lung open. When we take a breath in, we have the diaphragm that descends, we have the rib cage that expands, and this creates the pressure gradient. As we start inspiring, we have an equalization of the pressures, airflow stops, and then there's a relaxation of the rib cage, diaphragm returns to the normal position. So now it's slightly more positive than the atmosphere, and air flows out. So this is basically the pressure gradients that are created, and this is the transpulmonary pressure. It is the pressure in the alveoli minus the pressure that is in the pleural space outside of the lung. So work of breathing and its relation to compliance. So we have compliance is the measure of the lungs' elasticity. In stiff lungs, for example, ARDS, it requires more effort to expand the lung. We got that increased work of breathing. And we have COPDs that have actually pretty compliant lungs. So, they have ease to go in, but they have that air trapping. So it's that forced expiration, and then they get really superficial breathing. The whole point here is that once the compliance is worsened, there's a requirement for the patient to take a larger effort. They'll start making these larger efforts by increasing these negative pleural swings to try and draw in air. And if the compliance is altered, they are trying to generate that, but the work of breathing cannot assume that much to expand the lungs. So that's why positive pressure, whether non-invasive or invasive, is required. The point is that there are studies about patient self-induced lung injuries that can occur just with these large transpulmonary pressures between expiration and inspiration. These large swings can be as well injurious to the patient's lung. They can hurt themselves. There's also the opposition for the work of breathing, the resistive component. So this is the opposition to airflow. So when you get the asthma and COPDs, they have the increased work of breathing during inspiration. First of all, because they have the air trapping. So now they can barely, and you have the flattening, right, on the x-rays of the diaphragm. So you don't have the capacity to generate the appropriate gradient to have air flowing in and out. and on top of it, you you have you're not able to generate enough pressure to compensate for the resistive forces on inspiration or expiration. So then you'll see the forced expiration, even with the use of the abdominal muscles trying to force out the air. So again, this means that we need to, take charge, whether it's again non-invasive or invasive ventilation. So all this to basically say is work of breathing is a product of the compliance as well as the resistive forces in the airway. Higher resistance, more work of breathing; lower compliance, more work of breathing. So you have to always be thinking in mechanical ventilation, how much of this work of breathing is being assumed by the patient and how much is being supported by our vent support. And there needs to be a balance eventually. Obviously, talking in acute phases, we likely have to assume all that work of breathing. But always think as a respiratory therapist in the ICU that early spontaneous breathing prevents atrophy. So there's a balance where you want to support the patient enough so that they do not get fatigued, so that they're not creating these large transpulmonary pressure gradients, these swings. So you want to support enough, and you also want a reasonable amount of support from the patient, and that's the patient assessment, just looking at the patient whether they're struggling or not. So this is what we're focusing at for now: the intra-alveolar pressure, P-alveolar, and the pleural pressure. So it is the transpulmonary pressure is the alveolar pressure minus the pleural pressure, and which is usually, let's say here it says 5, but let's say 4. So 0 minus -4, 2 negatives make a positive. So you have an inflated lung usually because you have a positive transpulmonary pressure. The minute that the pleural pressures start creeping up and they're more than what is inside the lung, just makes sense. There's more pressure outside than inside. You will get that tendency to, with this negative transpulmonary pressure, to have atelectasis, to have the lung being, squished shut and unable to expand. So this is what we just explained during normal breathing. So, it's negative pressures being generated, like we just explained, the normal physiology that creates the flow. It equalizes. You have a passive release of the rib cage, and the diaphragm returns to normal, slightly more positive. So it's a very gentle way to breathe usually. When things start going wrong, and we have patients in the ICU, and now we have to take charge, things will get tricky because on expiration, if we don't have a proper PEEP setting and the pleural pressure on expiration is greater than the pleural pressure on expiration is greater than the alveolar, you are risking atelectasis, just basic physics. And then if on inspiration you have a pleural pressure that is way superior to the pressures being generated on inspiration, let's say an inspiratory pause, then you're likely going to have trouble expanding those alveoli. So this is the way we should be looking at things. And then after, if we have an inferior PEEP, like I said, that means that we have a loss in functional residual capacity. And therefore, let's say the example of 50% FRC of what you should have, or 25%, the fluctuations, are this pressure gradient that could be safe, whether it's pleural or drive pressures, but you're talking about 50%, then we should be thinking that, well, this drive pressure is likely being felt as double what I'm calculating, because I know that, let's say, the FRC is half of what it should be. If it's 25%, then you have this drive pressure that you're thinking is safe, but that's safe on a lung that is fully recruited, that has a normal FRC. The minute you start losing functional residual capacity, that means that, functional residual capacity are the alveoli that are functional and ready to take in a volume. So you can see that stress and strain has to be in the forefront of our mind. This is why I love electrical impedance tomography, where I can measure end expiratory lung volume, and I can apply greater PEEP to the patient, or mean pressures, or with APRV, using pressure, as well as extending time for recruitment, and looking and seeing the trend. Are we recruiting more functional residual capacity? Because if we are, that means more alveoli are coming to work and taking part of the stress. If you have a nurse in the intensive care, there's 20 patients, there's 20 nurses, there's a certain amount of stress and strain that is occurring. When half the nurses call in sick, and you only have 10 nurses or 5 nurses, then now you have the same amount of patients to deal with. The stress and the strain will be increased. It's a good analogy. So just quickly, let's say alveolar pressure is equal to atmospheric at rest before taking the breath in. The pleural pressure is -4. So transpulmonary pressure is measured by P alveolar minus P pleural, 0 minus -4. Sorry, this is supposed to be obviously +4. And like I mentioned, this is what creates our biological PEEP and maintains our functional residual capacity. Now, all of a sudden, let's say you have 0 before taking a breath in, and your pleural pressure isn't negative, in the negative, is positive. So you do the math, and now you have a negative transpulmonary pressure. And this means that the pressure outside in the pleural space is superior to the alveolar, and this will likely cause collapse atelectasis, reducing the functional residual capacity, increasing stress and strain. Things that can increase pleural pressures, think of pleural effusions, pneumothoraxes, obesity, intra-abdominal pressures, surgical issues in the abdomen, or pregnancy, and as well the position, standing. All this abdominal weight falls forward, and there's a lot less pressure exerted to the pleural area to squish the lung than when you're sitting. Now there's a bit more pressure, and then if you're lying flat, then you have all of that pressure. So somebody who has a large abdomen, whether pregnant, obese, patients liver failure with significant ascites, things like this, we have to take into consideration. Because if we're not, for example, like you have a patient that's 7 liters fluid positive, you see their arms are swollen like this, they're as hard as the table. Now, do you think that applying, a pressure plateau of 30 perhaps is as applicable to somebody with that isn't a 7 liters fluid positive? So, yes, these values are extremely important for pressure protective lung ventilation, but when we get to these extreme situations with drastic alterations in pleural pressures, we have to start individualizing the mechanical ventilation to these extreme cases. This is where you can use a transesophageal balloon pump to isolate more accurately the pressures within the lung. Or you can also use a electrical impedance tomography. that will look at the pressures that you're exerting and allow you to go beyond the plateau of 30 while still calculating regional compliance, looking for overdistension, let's say, in the anterior ventral areas of the lung. So all that to say, when your transpulmonary pressure is too low, you're going to have loss of volume leading to atelectasis. If it's too high, you'll have increase, in volume, but you have to watch for hyperinflation. If a patient is negative on expiration, as I said, that you'll get atelectasis. If the transpulmonary pressure between inside and outside the lung on inspiration is negative, then your lung's going to have a lot harder time to expand, so you're not going to be able to expand appropriately. There is a study, and I have the image in the presentation. I highly suggest you check out that study. So this is an excerpt from it. It says, in a healthy lungs, ventilator-induced lung injury will occur when the stresses result in lung volumes nearing total lung capacity. So that's like from expiration to inspiration, a gradient of 26. That would be like a very deep breath approaching total lung capacity. So it's for that reason that in the clinical settings, in patients that are intubated for maybe non-lung related issues, you want that swing to be 15 to 20, and that it be even more modest, 10 to 12 for ARDS. So in passively ventilated patients, the drive pressure it can be a good surrogate or a proxy. It does correlate well with transpulmonary pressure gradients. But we do have to take in consideration that the driving pressure that we're looking at has to do with the entire respiratory system, meaning that this drive pressure, this pressure differential, is to expand the lungs as well as the chest wall. So as long as the chest wall compliance doesn't seem or seems to be normal, then these two transpulmonary pressures and delta P's drive pressures correlate well. However, if your chest wall is getting stiff, if you have low chest wall compliance, okay, just understand that this drive pressure, let's say a 15, is not just being used to expand merely the lung, but it is also applying that pressure, and that pressure, I wrote wasted. It's wasted to expand all of the low chest wall compliance. And this applies when you have that obese patient with a really, big abdomen. You shouldn't be thinking of, we just intubated. Maybe this patient's intubated for something that has nothing to do with the lungs. Maybe they are on low FiO2s, the 25, 30, 35% or something like that. You just don't automatically be thinking, I'm going to put a PEEP of 5 or 6. Like already, if you see this large abdomen, you know that there's a significant amount of pressure, pleural pressure. The guy is not standing, he's sitting. He might be, lying. He might be lower, at 30%. Sometimes when you actually sit patients, as you know, sometimes it's like it actually works against them. It kind of like squishes their abdomen even more, kind of arches it towards the lungs. So it's just, a reminder to not start thinking of increasing PEEP when you start having FiO2 problems. You want to be thinking of setting the PEEP, whether you have the transesophageal balloon with these patients where you think that there is obesity, or alterations in pleural pressures, whether you have access to the balloon, or if not, these are probably the patients that you should set a optimal PEEP with electrical impedance tomography. You should look early on in that patient's intubation, the distribution of ventilation, and if this patient needs a PEEP of 16 to keep his big belly from squishing down the lungs, and he's on 25%, so be it. It's just basic physics. That's exactly what we have. We have a gentleman with a very, large, firm stomach, and we use the electrical impedance tomography, and his optimal PEEP is 16. If the chest wall compliance is normal, then again, we're talking about how they correlate the transpulmonary pressures and the delta P's. So, a little bit of just a quick, reminder. So when we're talking about the stress and strain of the lung, the stress is the force applied over a certain area. So if you have a large area, meaning let's say all your alveoli are functioning, you have a good recruitment of your FRC, then whatever stress, whatever vent power that you're applying to the lung, that force is nicely spread out in a recruited lung. Problems will occur when you have small areas, because as you get de-recruited, you have higher and higher stress of those that are receiving that vent power, and obviously the force of the vent will be concentrated in those alveoli that are taking part. And when we look at the strain, this is the change in the shape of the structure, the distension. So a change in a structure's size will be relative to its original size. So just understand that the strain in the lung occurs during the breathing cycle. And when we're looking at elastic materials such as the lung, more strain equals more stress. So, they're directly proportional. But just to complicate things, again, repeating myself now, sorry, but even so, you have the de-recruited areas of your FRC not doing their jobs, not taking part. Maybe they're snapping open and closed, which causes a whole other issue related to lung injury. But likely a lung in this situation, even the alveoli that are potentially open, even there's a large variation in time constants. So the lung is not yet uniform, and you will have, first of all, an increased strain in the areas that are opening, and within the areas that are opening, because of the different time constants, you can have areas that are, let's say, healthier becoming over distended. You overstretch them, you cause the injury. Now you have leaky capillaries, you have inflammatory factors occurring, and this just becomes a vicious cycle. So the study that I'll show you, it's somewhere in the presentation, I'll show you the title, goes into the stress and strain. So again, stress is defined as a force divided by the area over which it's applied. So intuitively, if a fixed force is distributed throughout a very large surface area of lung tissue, the forces, meaning the stress, will obviously be smaller than if the same force was distributed over a small area. So that's pretty much what I'm trying to repeat over and over, so that it's the message that everyone leaves with, ingrained in their head. And then stress is looking at the change in the dimension of the structure. So we're talking about volumetric strain, and we see that the volumetric strain during ventilation has both a static, right? So you can also over distend if your PEEP is way, way too high for nothing. So you can have this static strain, and then after, obviously, you have the breathing cycle. So you have a static strain that occurs as well as a dynamic component. So this study uses the example over here. I'll just use a pointer. So in this part, he's basically, the study is just trying to make us understand, yeah, let's say you have a safe tidal volume of 500 and you have, let's say, an FRC of 2,000. So that gives a strain of 25%. But if you're giving the same tidal volume, you're following the 4 to 5, the safe volumes, let's say they're in the ARDS, but now you have 500 of FRC and you have 500 of tidal volume, while the strain here that's occurring in those alveoli is fourfold. It's like 4 times the amount. So that's very important. So that's so these arguments are consistent with recent studies in clinical outcomes result in ARDS in surgical patients, showing that the effect of tidal volume on clinical outcomes are mediated by a variable associated with a lung strain. So the considerations also suggest, while reducing tidal volume, it is important. We're not poo-pooing tidal volume and or anything like that, but we have to take into consideration the tidal volume, how much of the alveoli is taking part in dealing with that tidal volume. So reducing tidal volume is important in an ARDS patient. The tidal volume is not the final determinant of lung volume. So for this this presentation, what I'm stressing is stress and strain. Okay, to look into this, to have a sound understanding of stress as well as strain. And then over here, it's basically what I've already said. I said of the alveoli, let's say, that are taking part, it's not going to be uniform as well. It's going to be certain areas that are receiving more tidal volume, and there's areas that will be receiving less tidal volumes. So on the micro level, macro level, you might be doing the 4 or 5 or 6 cc's per kilogram. But on the micro level, because of the heterogeneous nature of lung pathologies, most of the time, you can have an area that's getting 4 times the amount. So that's basically what I want to stress here. There's also something called alveolar interdependence, and that's what happens is that in a well-recruited lung, adjacent alveolar walls help stabilize the strain. Meaning, the minute, let's say, you have an alveoli and his neighbor collapses, once that there's, let's say, the collapse around these alveoli, then they're more at risk of being strained because they don't have the adjacent wall to keep the proper alveolar shape. They can have distortions, which can lead to lung injury. Another interesting thing is that, let's say you have an area of collapsed alveoli and you have an area of healthy alveoli that are adjacent to the collapsed alveoli. So on inspiration, it goes like this. And then on expiration, the collapsed alveoli actually pull, right? Because you actually have healthy alveoli beside collapsed alveoli getting strained, getting pulled on expiration. So these collapsed area actually tug on the healthy alveoli. So you're not only getting strain possibly on inspiration because you don't have those alveolar adjacent walls to help prevent a distortion of the alveoli. You also have a strain that's occurring because there's a distension occurring on expiration. All right, so let's just go through the basics of mechanics. We're looking at plateau pressures. So we perform an in volume control or pressure control mode. The inspiratory pause stops gas flow, removing resistance. So you have your peak pressure, you do an inspiratory pause, you'll get a drop and a plateau. So the difference between the PIP and the plateau has to do with airway resistance. So a common misconception is that plateaus cannot be done on pressure control mode. Yes, they can be done. Now, you obviously, the flow on pressure control is decelerating. You're going to have a lot less resistance created by the higher flows than the constant flows that we see on AC/DC. So you get more of a drop because there's usually more flow perhaps, and it's not decelerating. But if in an ACPC, you can attempt an inspiratory pause, and you will get a dip, especially in patients that are allowing themselves to be ventilated. So it can be done on pressure control. The thing is with pressure control is there's no flow limitation, right? There's no set flow. So when your patient is on pressure control and now perhaps they're taking breath, they're well synchronized with your ACPC setting, what can happen is the vent will deliver a set drive pressure or a delta P, right? So a pressure difference, a pressure gradient. And they might be taking a breath also at the same time. So they're able to pull in additional flow, which means additional volume. So when you have ACPC and you're pressing an inspiratory pause at the end of the phase of inspiration, you can potentially, you will get a plateau that is above what the set peak inspiratory pressure on pressure control would be. So there's a lot of articles that are discussing this in publication. There's a lot of discussion on forums and stuff where people are having issues and thinking that when you have a plateau or when you're setting a peak inspiratory pressure like we do on the V500 or setting a delta above the PEEP, whatever that peak inspiratory pressure is a plateau, but that is a misconception. So that's why I wrote in red on spontaneously breathing patients on pressure control. The patient effort can cause higher plateaus than the set PIP or pressure control. So the pressure control is a PIP in the V500. This is due to them drawing in additional flow, which is volume. I have actual pictures towards the end that I could show you quickly. To get your total PEEP, you also have to close the expiratory valve. So you do an expiratory pause. You'll, if you have a total PEEP or intrinsic PEEP or auto PEEP, using various names for it, you'll get an increase. We can see it here. So let's say this is the set PEEP, but when you close the valve at the end of expiration, it rises. And this here, you freeze frame and you measure your total PEEP. So if you're having issues with total PEEP, if it's because of bronchospasm, optimize your bronchodilators, look at your inspiratory time. Perhaps you have a high respiratory rate set and maybe your inspiratory time is like 0.9, it's too high. Maybe you should reduce it. So just keep, just a reminder of looking at the IE ratio, allowing for enough expiration within that ratio can help as well. So just caution when you have asthma and COPD patients that, let's say, are very acidotic, that high respiratory rates could cause significant air trapping, which you might have a minute ventilation, but you're air trapping, so you're not allowing them to expire that stagnant air with CO2 to get another, deep breath in. So you start low in these cases with the respiratory rate. You do your total PEEPs. Then you can sneak up your respiratory rate, always looking at your total PEEP to see what's the highest rate I can get without aggravating or making the auto PEEP any worse. So what you're going to see on the vent is that on expiration, the flow does not reach zero, and then you'll receive the next breath. So when you're doing your patient assessment, look at the end expiratory flow. You see this, then you likely have auto PEEP. You do the expiratory pause, you can calculate it, and you can make the adjustments we just spoke about to improve that. Looking at the drive pressure. So the drive pressure is the difference between the plateau, so the inspiratory pause, the peak inspiratory pressure will drop to a lower pressure. You've removed the resistance, you have your plateau. Then you do your total PEEP, and then after you subtract the total PEEP from the plateau, and this indicates the pressure required to deliver that set tidal volume. There's the equation on the bottom, plateau minus total PEEP. So looking here, this is the drive pressure. Let's say that it was a expiratory pause. This is your total PEEP. This is your plateau. This is your drive pressure, plateau minus PEEP. And more literature is coming out, seeing the importance of drive pressure as an indicator of mortality. So are we increasing the chances of mortality with the way we're ventilating when we start having rising drive pressures above 15, or the study that I'm citing, you look at the patient's initial drive pressure, and now there's a change of 7 and beyond, then mortality as well in the study. So all of these calculations are not useful or as useful to us if we only start calculating all of these mechanics when we start seeing things, plateaus passing, oh, now I better start calculating all these things. No, this needs to be calculated. The more calculations, the more variables, the better the trending. And when we suddenly see changes in these mechanics, that's an indicator for, at least at my hospital, to say, okay, things are getting more complicated. We need direct visualization of the distribution of ventilation within the lungs. So let's put the electrical impedance tomography, the Palma Vista, and let's really individualize. Let's make the adjustments. All right, so let me see if we're back on hospital Wi-Fi. Sorry about that, guys. Looks like things are returning. All right, so share screen again. Hey, Xander. Hey, look at that, guys. My mom is here. Hi, Mom. I'm already developing loyal fans here. All right, entire screen. Current slide. Yeah, so this is the study that I've been citing: driving pressures and transpulmonary pressure, how to guide a safe mechanical ventilation. Here's another screenshot of the study. So you know, I don't like just reading stuff in a PowerPoint presentation, but I think just reading it, a few of the citations is worth it because it's very, very important information. So, in the intensive care and analysis of randomized trials of ventilation in ARDS patients, found that an increase in driving pressures of 7 was associated with increased mortality. Even if the plateau pressures and the tidal volumes were in the accepted range of protective lung ventilation. Below 30 of plateaus, the tidal volumes were below 7 mLs per kilogram of probably ideal body weight. So in that study, a driving pressure greater than 15 was associated with increased mortality, and a subsequent investigation in ARDS patients with driving pressures above and below that threshold found that higher driving pressures were associated with a higher lung stress. So, so over here, plateau pressures, even if they're below 30, even if we're doing 6 to 8 in normal patients, or 4 to 5 more modest tidal volumes, which we should, it's not enough to protect. There's more and more evidence, and this is important for our day-to-day work in the intensive care, that it is the drive pressures are starting to show evidence that they are truly a very important marker for patient outcomes. So to calculate our static compliance, which is the change in volume per unit of pressure, we do an inspiratory pause on volume control or pressure control. Then you measure the plateau pressure and the exhaled tidal volume to be more accurate. You perform the expiratory pause, the measured total PEEP, and you take the tidal volume. You take and you divide that by the difference of the plateau and the total PEEP. So in non-intubated patients, normal compliance is usually 80 to 100 milliliters with every centimeters of H2O. So for every unit of pressure, you get about 80 to 100 liters. So that's a nice, easy, supple lung that expands easily. Intubated women, they say 35 to 40. Men, 40 to 50. Obviously, the size of the person has an effect, but generally between 30 and 50. I should have wrote 50, but generally for intubated patients, 30, 50 is pretty good. Looking at airway resistance, so that's the amount of pressure that's required to deliver a set volume as at a given speed. So measured in centimeters per liter per second. Don't forget our flow when we divide that flow is always in liters per minute. So you have to turn that into seconds by dividing our flow by 60. So higher resistance, the more pressure is needed. Lower resistance, less pressure. So your resistance is look at do the inspiratory pause. So that will make your peak inspiratory pressure drop to a plateau because there's no more movement of air, and you divide that by the flow, but your flow in seconds, so in liters per second. Divide your liter per minute by 60. So to calculate raw, that you do need to go to ACVC, to volume control. So raw resistance, airway resistance calculations cannot be done in pressure control mode. So constant flow, square waveform, set it on average between 40 to 60. Some literature says as high as 80, but pretty much average 40 to 60, 50, let's say, being the average. The inspiratory pause. So a nice good plateau is achieved with 3 seconds, and then you take your peak inspiratory pressure, you subtract the plateau, and you divide that by the flow in liters per second. Normal resistance in non-intubated is 0.6 to 2.4 of pressure for every liter per second. In intubated, what's acceptable is 6 to 7 or below. Things start creeping up. You're starting to have higher and higher airway resistance. Here is some of the pictures. So you have a pressure setting of 18. So here in the V500, you're setting a peak inspiratory pressure. So here is the 18. But when you press an expiratory pause, you remove the airway resistance, and the 18 drops to 14.9. So there's still a significant 3.1 difference. So the peak inspiratory pressure, there is an inspiratory time. There's gas flow occurring. So it's valid to do a inspiratory pause on pressure control. And also because you're on pressure control, and then go do the optimal peak, because your true drive pressure is that. So if it's 18, you just knocked like 3 units of pressure. So, and then after, let's say it's 8, your PEEP, you have a total PEEP of 9.1. So now you have another unit of pressure. So you might be thinking that you've already attained a drive pressure of 15, when in reality, no, that your setting dropped by 3 and the other one is by 1. So you have you might be only at 11. So it gives you room to breathe, where you could be like, oh no, I'm not actually past the danger zone of drive for drive pressures. Now you might have somebody here where they are taking a breath with they're well synchronized, and they're taking an inspiration. So you have the vent here that is set at 16. You have a PEEP of 8. So you have a set delta of delta pressure, or a set drive pressure, whatever you want to call it, of 8. So a PEEP of 8. Then after it's going above 8, so you have that pressure controlled delta P, or pressure support level of 8 units of pressure, giving you over here, without the expiratory pause, a peak pressure of 16. And many people think that that's the plateau. Now, because there is no limit to flow, this patient, while the vent's doing its job of giving the pressure control breath, can draw additional flow, which is additional volume. So the breath is has a lot more tidal volume than if he was just passively allowing the vent to push that delta. And when you do the plateau at the end over here, at the end of inspiration, we see that it increases to, I believe, 26.8. So that is 10.8 above what you would expect is happening in the pressure in the lung. No, the pressure in the lung is not being limited to 16 centimeters of H2O, but has actually 26.8 centimeters of H2O. And the drive pressure, which we were thinking, we set 8, is physiologically, because of the patient effort, is 18.8. So that means that he is assuming his work, he is generating 10.8 above what the vent is supporting the patient with. So what does that tell us in our practice when we start seeing this? Well, let's look at the patient. It's like additional flow and volume on AC/PC. Is he doing it and he looks very comfortable? There's no work of breathing. If that is the case, it's an indicator that, wow, like he seems to be assuming a good deal of the work of breathing with his own muscles, and he's able to generate a significant volume, and so hey, maybe I should reduce my vent support by further reducing your pressure control setting. However, if the patient is breathing above, and you do the inspiratory pause, it's above, but you look and the flow waveform is very narrow. They're struggling. They're using accessory muscles. Then we know that perhaps we should be increasing our pressure control level to alleviate that person's work of breathing that they're assuming. Or we should be thinking of, is my PEEP optimal? Is this patient struggling like this because there is very little alveoli taking part in the breathing? So again, this is where you have to start thinking of, is the PEEP optimal? Can I recruit any alveoli? The more alveoli that you are recruiting, naturally you'll have better compliance, because compliance gives us an idea of lung aeration. And if you have a improving compliance, then it just makes sense that you'll need less and less units of pressure to generate X amount of volumes. So high drive pressures, time to at least, in my case, put on the electrical impedance tomography. Let's see if this patient is recruitable. Let's find the optimal PEEP. And if you do not have that technology, it might be worth using, if you do have the technology, the balloon pump. If you don't have that and you don't have the EIT, then you're going to have to do old school and do the calculations for optimal PEEP. So this can apply just like I showed you on ACPC. I just have a slide just to show you that spontaneously breathing patients during pressure support ventilation as well, they can generate negative pleural pressures that are large enough to result in quite large tidal volumes, resulting in end inspiratory plateau measurements that are, just like I showed you in ACPC, set above the peak pressure. And these plateaus can be measured with a simple inspiratory hold, and this allows for the assessment of the physiological drive pressure. So technically, you can do this, with pressure support ventilation. This is to show you. So here's pressure support ventilation, 8 and 8. So you see that here it's reaching 16. You would think like, oh, okay, well, that's it. There's nothing more than 12 of peak pressure being generated, or sorry, 8 and 8. I don't know how to count 16. But when you actually do the inspiratory hold, you realize that it's not 16. It's actually, you see the effort here and here, end of inspiration, the expiratory pause, a nice plateau, and we see here 28.6. And again, you look at the patient, are they generating, are they struggling? You can see that the patient is not struggling just by the nice inspiratory flow waveform, a nice normal inspiratory flow waveform. So that's just to show you that it applies as well for spontaneous breathing patients. So mechanics on pressure control ventilation mode, the only thing you can't do is measure airway resistance. So no matter what, whether it's ACVC, ACPC, inspiratory pause, it will stop the gas flow, it will remove the airway resistance, and a plateau can be measured. Plateaus, we're still going with negative 30 and trying to keep the drive pressures that correlate with increasing mortality of intubated patients. There's more and more studies coming out, so that should always be on our mind. So I'm just repeating myself. You need the total PEEP to measure true drive pressure, and just repeating myself, when a patient exerts effort on ACPC pressure control, they draw additional flow, aka volume. So you'll potentially get measured plateaus that can be above the set parameter. And when you do see those things, might not be clear the way I wrote it, but I'm sending this to the staff after. It's just to say, when you do see that, just understand what is above is the patient's own work that they're doing. And if they are assuming that work and there's no work of breathing, they're chill while they're doing that, that is a sign that you can further reduce the vent support. But if it's above and they're struggling, then probably you have two things to do. Go alleviate the work of breathing, because you don't want them to get fatigued by increasing your own drive pressure that's set to get closer to where the patient is. Or you have to figure out, is this a patient de-recruited, and does the patient have recruitment of their FRC? Do they have that potential? Because that is really what's going to fix your increased work of breathing. It's recruiting more alveoli. All right, thank you very much. That's the end of the presentation, and just going to stop here. I don't see any questions at the moment, so I will end the stream right now. Thank you very much for those who will show up later on and watch this video. All right, see you. Bye-bye.